again. So sometimes it can be like a hemoptysis. Sometimes it can be like with some expectation also. We cannot say differently, but purulent sputum or like that is uncommon. That is first thing. So cough, if at all, if it happens in heart failure, it happens more in supine patient. That is because in supine, pulmonary venous pressure increases and lung pressure increases. That's how it gets blocked. But the infection of lung, it doesn't matter whether it's supine or standing, both it can be there. And both elements should be. Sometimes the respiratory tract infection also can increase when somebody is kind of right. So that is regarding the cough. So breathlessness is different per se. How the heart failure breathlessness is there?
Breath on exertion and things.
Yeah.
And
lung also can get an exertion.
orthopnea and paravalvular nocturnalism.
That is the best indicators to correct cardiac arrhythmias. But breathlessness of the lung generally not that severe like 3-4. It can be generally 1-2. Right? Respiratory tract infection can make it 4 also. But by and large, restlessness class 3, class 4 is unlikely to be respiratory breathlessness. Asthmatic attacks in between, episodic wheezing, the episodic status asthmaticus can happen even with lung. Or precipitation by infections also can happen. But by and large, it is not common. Severe types of so like that. Okay. Then PND orthopnea, why can't it happen? Orthopnea again, some people say it can happen even in lung conditions, right? But PND is the specific for cardiac. Cardiac can it be right side? Cardiac is left side again. It indicates increased pulmonary venous circulation. LV dysfunction, mitral stenosis, mitral regurgitation, something like that. Right-sided one again can lead to orthopnea, but not PND. Right? So that is the breathlessness thing. And breathlessness precipitated by some event like chest pain, something suggestive of severe heart attack, things like that. Again, it could be more likely to be leading to cardiac cause. Or respiration breathlessness leading to before lung infection out is more likely to respiratory cause. So when somebody is saying breathlessness, apart from the standard thing we lost, mode of onset, duration, progress, aggravating factors, relieving factors. So on exertion is increasing, aggravating, it is likely to cardiac. Rest is decreasing cardiac. Respirating factors like this. So worsen grade, the more severe it is cardiac. This is heart failure presentation. Heart failure, then it can be like systolic dysfunction or diastolic. You know this, no? Yes. Heart failure with preserved ejection fraction, we call it. Heart failure with low ejection fraction, depressed ejection fraction. If all input weighted, heart failure, mid-range ejection fraction, input radiation, heart failure with recovered ejection fraction. As it life is there, make it simple, no? But as we keep knowledge, as we get anything which is related to patient management, you have to give importance. Why they made it is management is slightly different. Okay, heart failure with recovered ejection fraction, recovered LV function. Many people are stopping tablets suddenly. Goes to physician or somebody stops everything recurs. So you are not supposed to know it because that can have a tendency to come back if you stop it. Okay, so that's why the entity created like that. What is the standard example for heart failure with recovered ejection fraction?
Septic cardiomyopathy and all after infection resolving.
That is one. But females should know more. So there again, one more thing is they'll come with pregnant again, it again come. Don't advise them to avoid have pregnancy because that's importance of it. Don't stop the medication too often, too soon, and suddenly it will recur also, right? So that's the importance of knowing it. So what are the other causes of recoverable heart failure, whatever we call? One is pericardial cardiomyopathy, one is sepsis, you said. Any other thing? Oh, it's very common. COVID infection, viral, cardiac bag, all that came. Okay, what one? Infections are gone. One cause. Yeah.
Heart failure.
Anyway, all high output pressure. Per se, not because of heart damage per se. It will be normal. Okay, correctable factors, secondary heart failures. When you correct the secondary factors, it's not only come down, like anemia, thyrotoxicosis, all that. But per se, heart LV function was less. Now do you prove? First, is it possible? Many times, no, echographer improvement or depressing is there. Echo is subjective. Who does echocardiogram is very important. Sometimes the patient get worried, terrified. They write more 10% more, 10% less. It's all subjective. Okay. So, but even if it is done correctly, so what are the other conditions in which pumping can become normal? So it's beauty, no? I feel very great when you make the heart function normal. Only God and medical professionals can do it, no? So wherever such things, you should know it. What you did, nothing. What was there, you corrected it. That's all. It became all right. If you not corrected it, you would have died also. No? That's great, no? So you read this. I tell later. That's a great thing, no? Heart is the 30%. You gave something, heart became normal. Very good. No? I always keep telling medical profession, nursing profession is a great profession. Don't equate with money. Yes, you save life, you relieve suffering of needy patient, though it's a God's grace. You're lacking a channel. But no other profession has this. Ambani, can you do it? Mukesh Ambani? Tell. So, explain that you are very great, more great than that. Please, we should be happy like this. If not anything. No, but really also I feel that's why still we are respected in society. Why you are respected? You don't have bank balances like Ambani. Okay. Sometimes మన పక్క వాళ్ళు రెస్పెక్ట్ ఇస్తారు ఏ అమ్మాయితో ఎప్పుడు అవసరం పడుతుందో తెలియదు అనుకున్నా అండ్ ఇంకొకటి చెప్తా మనకు వాడు పోలితేనేమో నాకు నచ్చుతుంది డాక్టర్ ఇట్లా అయిండు అని వాడు అంటాడు పట్టించుకోవద్దు దాన్ని చాలా ఫీల్ అయిపోతారు ఓ నా పిల్లని ఎప్పుడు డాక్టరే చేయంటాడు ఇంకోటి ఇంకా ఎక్స్ట్రీమ్ ఐ విల్ మేక్ మై డాటర్ పోల్ డాన్సర్ బట్ నాట్ డాక్టర్ హౌ టెరిఫిక్ ఇట్ హౌ బ్యాడ్ ఇట్ ఈస్ అండ్ మెడికల్ ప్రొఫెషన్ another is to make minted money and he's talking like this so bad it is no should profession is a different profession good bad is there everywhere how can I totally say negative about this profession no it is I feel very proud of this profession I don't know how you people feel you may be problems are there like this that is okay but profession cannot be said a bad profession it's okay tough work great but good things are always tough in no okay deviating I keep talking like this because I want to inspire people I feel very bad when they say bad about medical profession okay కొడుతుడు అనేది is not acceptable anywhere okay I'm not supporting that patients attendants coming and beating all that husband wife ko padadi కొడితే వెళ్ళిపోతుంది or reverse also can happen nowadays but that physical assault is not correct in any form anywhere obviously it is not acceptable in medical profession at all. I am not supporting it. What ఏదో వచ్చిండు ఏదో అయినా ఎక్కడ రావచ్చు కదా అది ఓకే ఇప్పుడు వాడేమో సార్ దేవుడు మంచి తీసి నాకు స్టెట్ మంచిగా పెట్టిండు సార్ నా పంపింగ్ మంచిగా అయింది హార్ట్ అని ఒకరితేనో క్వశ్చన్ అంటే కూడా పడాలి మనం ఐఎమ్ నాట్ సేయింగ్ దెబ్బలు కొట్టాలి అంటలేదు వాడు అప్పుడప్పుడు నచ్చదు వానికి ఏం ట్రీట్మెంట్ ఇచ్చినా బేకార్ ఖరాబ్ అయింది అంటాడు వాడు దట్ ఈస్ అవర్ క్వశ్చన్ అదో So, good bad is there everywhere. So, don't negate medical profession in general, right? All of you like medicine, they took it, or by default you can. Like, you know? If you don't like it, it becomes miserable. I'm telling you again. If you are forced to do a work which you don't like, you will be feeling miserable about it, no? You should enjoy it. Okay, by default, you enjoy it. Otherwise, you will feel more miserable. Day to day life, it becomes miserable. You don't like it, but if you really like it, there is no profession as good as this. The patient comes with breathlessness to ER, blood pressure of 220 by 120. Meer chese pani cheptunanu. Suddenly treat that fellow with NTG, give Lasix, put oxygen. Vaaniki chachipodani vache relief chudandi vaanlo one face lo aanandam chudandi. That should give happiness to you. What we did? The channels, but we did it. If you don't come that particular time, you will arrest. You did it. So that's a great thing, no? You don't feel it is great, no? Patient of acute MI, severe pain. Okay, 9 out of 10 pain, I said. 10 by 10 in labor pain, I said. 9 out of 10, severe pain. Or padukoledu, కూర్చోలేడు, restless ఉంటాడు. మీరు acute MI patient చూస్తే మీరు acute MI అని చెప్పాలి. అట్లా వస్తుంది ఎక్స్పీరియన్స్ లో. వాడు పడుకోలేడు, కూర్చోలేడు, వానికి ఏమైతుందో తెలియదు. Restless, severe pain. You gave something, you lytic therapy, one shot of tenecteplase, artery open, fucked pain gone. Great. Or you took it to cath lab, opened up the artery, finished. Patient arrested, you did massage, took it to cath lab, opened the vessel, is normal. Great, no? So only our profession has this greatness, no? So coming back to heart failure, if you treat that patient on time, he will not go to this heart failure. If it doesn't come, that is his state. Patient doesn't come for treatment, he'll think gas, he will develop total muscle damage, heart failure happens, and he's going to end stage heart failure, right? So that is our breathlessness, other presenting features we should understand. But now the entire concept is going towards prevention. That is why more stress is given on prevention of heart failure, right? That is why they introduced this concept of staging of heart failure. You know this staging of heart failure? I'm not talking about grading of class of heart failure. Heart functional class is different. This is a staging of heart failure. Anybody know what? Japan?
ABC is in the stages for this.
ఏంటిది వాడు ఇది ఉందని ఏబిసిడి మా పాప కూడా చెప్తుంది ఏంటది ఏబిసిడి చెప్పండి కరెక్ట్ ఏమన్నా అది వేరు వెట్ డ్రై ఏంటంటే అది because when the lungs are congested you call it as wet when the trucks are dry and the absolute heart failure
A is pre.
Simple amma గుర్తుపెట్టుకోండి I will tell you to understand the concepts no you need not rectify it. Please take this point always. You now you have heard of me talking about staging of heart failure. You will never forget in your life what stage of heart failure. It's so simple. Okay. Stage A. Stage A is what? At risk of heart failure. You don't have any structural hearts. Okay. What is at risk? Hypertension failure is at risk. Diabetes failure is at risk. High cholesterol failure is at risk. Alcoholic failure is at risk. Anybody who is at risk of heart failure. That means you have only risk factors, but no definite evidence of LV dysfunction or structural heart disease already. Why they made it? That is the prevention is important for that. That is stage A. So any risk factors will come in stage A of heart failure. It looks funny. There's no heart failure. Why are you risking it? But if you neglect it, it will go. That is to prevent the concept of, to propose the concept of prevention, they made it like that. Okay. That is stage A. Stage B, ఈ రిస్క్ ఫ్యాక్టర్స్ ఉన్నాయి కొన్ని రోజుల నుంచి పట్టించుకోవట్లేదు మీరు స్టేజెస్ వచ్చేసినాయి హార్ట్ there is development of LV dysfunction or sometimes there is development of LV hypertrophy or there could be evidence of diastolic dysfunction and echo, things like that. So structural heart changes have already set in the heart, but no symptoms. No? Why they made it like this is even in the asymptomatic LV dysfunction phase or asymptomatic structural heart deterioration phase, you start treatment, they will benefit. Okay. So it should be considered as equivalent to symptomatic heart failure. You know asymptomatic silent angina? You heard about it?
Yes.
Silent ischemia. Silent ischemia treatment also has same benefits like symptomatic angina. Right? Similarly, heart failure is asymptomatic also. Maybe risk profile worsening of mortality is slightly less, but still the benefits. That's why they gave them. Third is anyway you'll make out heart failure. That is symptomatic heart failure. See, no? Symptomatic heart failure, he has changes, he might have changes, but he has symptoms. Symptomatic heart failure. No? Stage D is end stage. End stage problem is symptoms are so severe, whatever you do, symptoms won't go. It is an end stage heart failure, right? So those are the candidates in which heart is usually dilated, 20% EF, he is getting into arrhythmias, he gets into IV infusions, dobutamine, arrhythmias, AACDs, devices, heart failure, every nonsense. So that is the end stage where you go to cardiac transplant, things like that. Simple, no? A, B, C, D, you need not muck up, no? A is only risk, B is worst. In between B and C, B is asymptomatic, C is symptomatic. Where is the question of forgetting this, you tell? Huh? Even if somebody wakes you at night, you can tell, no? But always people get confused between staging versus functional class. That you shouldn't do. Okay? Functional class we discussed before, no? No? Functional classification I have discussed in symptom analysis. Discussed. So how, what is functional class 1 and what is the normal patient? How will you distinguish that? Can you tell this? Sorry. What is functional class? Breathlessness. Functional class 1 breathlessness. How do you describe it? Tell me.
There's no limitation.
Okay.
Yeah.
So breathlessness and exhaustion, everybody will get it.
After how about the patient records?
Yeah, then you want. And second thing is normal people will recover faster. Whereas this may take some time. That's one. Second thing is this classification is only for documented symptom and heart failure patients only, heart disease patients, not for everybody. That's how the class is made. Otherwise, everybody will become functional class 1. Disease. All of us become breathless and more than ordinary activity. You just remember the word ordinary activity. Ordinary activity is 2. More than ordinary activity is 1. Less than ordinary activity is 3. And the PN is also 3. At rest is 4. We try to make things simpler for you. Okay? Ordinary activity, if you remember, ordinary activity is what? What is ordinary for you may not be ordinary for laborers. But what is ordinary activity for that particular person? Remember this, easy, no? Ordinary word, one word, if you remember. More than that symptoms is 1. Ordinary is 2. Less than that is 3. Rest is 4. PND is less than ordinary, equals 3. Aptopnea at that rest is 4. Okay. So these two shouldn't be confused. Staging is different from functional class. Right? So then other type of concept in heart failure you should understand is what is systolic heart failure? That is generally preserved ejection fraction. What is diastolic heart? Okay, and that is again they say it as preserved ejection. So what is it? How is it different? Which is more better? Both are better. How is it different? Why is it happening? Why? What is the main mechanism why preserved ejection fraction and reduced ejection? Reduced ejection fraction, understandably so. No, what is the heart is not able to pump, blood is not coming out, not supplied to all the parts of the organ. So fatigue happens. That's simple. At the same time, when the pumping is not happening, the pressure, LV endoscopic pressure is increased. So LA pressure is increased, the pulmonary venous pressure increases, so it becomes breathless and TMD. Understand? But if heart is pumping normal, then why is the patient becoming breathless? In diastolic dysfunction, so-called heart failure with preserved ejection fraction. Why? What is the mechanism there? If you understand the mechanism, you will not forget. Okay? Why is it happening? And one more thing I'm telling you, any amount of knowledge can be taken. Okay, don't think of why is I telling all this for MD general student. It's not required for us. No, it's not like that. It can be anything. Yeah, I can take any amount of knowledge even on space. Something ISRO launching a rocket, we should not think it is useless. But anything related to medicine also it is important. Don't think about why this is all this talking from stuff like cranky examiner might come and ask you also. But sometimes it may not be relevant to your exam also. Still, knowledge is not poison. Any amount of knowledge should be learned. Daily you keep a focus that you should learn always something new. Right? So why is it? Diastolic dysfunction, why is the patient having breathlessness? Breathlessness రావాలంటే ఏం కావాలి? Patient should have increased pulmonary venous pressure. Clear? When the lungs venous pressure is increased, the lungs are congested, is becoming breathless. One thing is pumping is very slow, so it's not pumping out. So LV endoscopic pressure is increasing. That's why LA pressure is also increasing. Right? Simple, there is no problem. But where LV endoscopic pressure is normal, because LV is pumping aggressively. But still LA pressure can be high, you should think. If LA pressure is high, LV is obviously pulmonary venous pressure is high. So what are the conditions in which LV ETP is normal, LV contracted is normal, but LA pressure should be high? Or second paradox is, even LA pressure is normal, but pulmonary venous pressure is high. These two are only possibilities for increasing pulmonary venous pressure, right? Leading to heart failure with preserved ejection. So what are they? Some obstruction to the mitral valve. Suppose cital stenosis, LV is normal, but obstruction is there, so LA pressure is high. Or regurgitation also. Regurgitation happens, LA pressure goes, right? Or hypertension with left ventricular hypertension, right? Contracted is good, but relaxation is a problem. Blood won't be able to freely come to from LA to LV. So LA pressure increases. So cardiology is brought hemodynamics. It's a very beautiful specialty. I love it. To understand the basic behind it. You don't need to mug up it, right? So in a severely hypertrophied LV, so contractility is okay, but it's not relaxing properly. So LV LA pressure is again going up. So LV hypertrophy problems. It can be because of hypertension one, or it can be aortic stenosis, LV hypertrophy, or it can be hypertrophy cardiomyopathy itself. Heart muscle is thick. All these could be again causes for preserved ejection fraction intervention, right? So this is I said LV EDP is normal, LA pressure is. So many more may be there. I give you some examples for you to think. Where LA pressure is also normal, but pulmonary venous pressure should be high. Is it possible? Must be possible. That's why I'm asking.
Pulmonary artery hypertension.
Huh?
Primary pulmonary artery hypertension.
No, that's also there, but I'm talking pulmonary venous hypertension first. Oh, pulmonary arterial hypertension, artery pressure will be high. Venous pressure may be normal. Later stages when the goes to LV dysfunction, it can both can come. Where pulmonary vein gets occluded, no, think simple. So suppose something constricts about pulmonary veins. LA pressure is not high, but constriction is happening at the pulmonary vein where is entering LA. So pulmonary venous pressure can be high. Where it can happen? Huh? Okay. Embolism of both systolic and diastolic. Chronic agreed. Suppose chronically you can, right? I am asking you specifically where pulmonary veins are constricted. Where they enter, where how can they get it narrowing? Suppose pericarditis is happening, constrictive pericarditis. So pulmonary veins can get narrowed. Okay. Some infections or various things again, the same mechanisms could happen. Or some sort of you saying some tumorous growth at the where point of entry that could happen. She said LA myxoma, partly correct, but generally an LA myxoma could have some pulmonary LA pressure also may be high, but sometimes can be normal. Agree. Pulmonary venous pressure only can be high. Right? Later stages like pulmonary artery gets into fibrosis, then veins also could get into fibrosis. Entire thing that is a chronic thromboembolic PAH or a chronic PAH of any cause in the later stages can also go into pulmonary venous hypertension and LA pressure can still be normal. So those are some of the conditions. So those are the conditions in which pulmonary veins are at high pressure in spite of pumping being normal. This is supposed to be a little more dangerous than people with systolic dysfunction, because symptoms are more aggressive and the milieu in which it is happening is also different. Generally, elderly people who have diastolic dysfunction or like hypertension, diabetes, elderly people are more likely to get into diastolic dysfunction. Younger patients are more likely to get into systolic. And logically so, heart thickening happens over a period of time, thickening increases. That's how over a period of time, diastolic pressure, LV dysfunction symptoms come, increased LA pressure symptoms come. It takes chronic, long stand. Suddenly patient develops heart attack and overnight he becomes breathless. It's unlikely to be diabetes. It's more likely to be systolic. So chronic history will be more likely to be because of preservation fraction. But anything changes can be. Again, plus minus is possible. I said chronic history versus short history. Which one are more common like that? Versus chronic, right? Aortic stenosis is short. And similarly here, the more longer the history, generally it is likely to be diastolic heart failure or like heart failure preservation. Shorter is, and so those are the differences. That another conceptually we should understand about heart failure. So I told about symptoms, I told about type of heart failure, etiological differences or etiology of it also I told. Then we'll come to evaluation. Evaluation of heart failure. So what should we do? What are you should do tests? I tell you one test. I give you a chance to do only one test. Diagnose heart failure. What did you tell? Is there any antibody? Good ego, yes. But it's not easy to assess the diastolic dysfunction. That's okay. But heart failure is there or not, to tell it is okay. But sometimes, very rarely, little normal variation types also could be there, but it won't be so high anyway. But echo done properly is good, okay. But many other times, echo is done dependent on operator. Who is doing it is important. Systolic heart failure, by and large, a machine itself gives. But to pick up diastolic heart failure with physical expressions, there's some criteria. So grade 1 heart failure, diastolic dysfunction, grade 2, grade 3. I'm not going to all details, but there are some stages grading also described in diastolic heart. So echo is the most important modality diagnose heart failure. Before that, suppose the ECG is there. And COPD, asthma versus heart failure. What is more likely to say a patient is having heart failure than asthma? Maybe there may not be there again. Okay, 100% diagnostic, you can't have it. ECG is normal, it's again normal in both. You can't argue like that. What are the pointers to say is more likely to be heart failure, not because of asthma? Otherwise, versa in ECG.
LVH.
Okay. LVH is there, but LVH could be there even in thin chest in asthmatic patients. But by and large, LV hypertrophy could say that it is cardiac. One agreed. Yes? Let us finish LV. LVH strain patterns, HTT changes are more likely to be heart failure. She said LA atrial overload. Okay, P wave changes, dilatation, the hypertrophy. Again, suggests that that is only left atrial overload. Sometimes right atrial overload, the life is complex. It could be there even in lung problem. Okay, right atrial overload can be there in COPD. Right atrial overload can be there in asthmatic bronchitis, things like that. But left atrial overload generally points to heart failure. But sometimes biatrial enlargement could be there. Left should be there, right could be also there in the late stages. That is more likely to be heart failure. Okay. In the ventricle, in the LV, QRS, anything else suggests like heart failure or versus asthma? One is hypertrophy itself. I said associated ST changes. Anything else? Sorry. No, sorry. Yeah, QS complex. Totally QS means it is like more likely to be MI. If not QS, many times it will be like notching patterns, like LBVP, RBVP, some widened QRS. Those are the pointers to say it is heart. Unlikely in cardiac, unlikely in lung, right? So any sort of ECG abnormality, let us put it this way, more likely to be heart. But sometimes accepting some very rare findings like a right atrial overload or right ventricular hypertrophy, which could be just because right ventricular hypertrophy means again the heart is also involved there. You can't say it is only a problem. So by and large, ECG abnormality points towards heart failure of cardiac cause, breathlessness of cardiac, right? X-ray let us come. Okay. You may say, why is foolish talking about X-ray, ECG, directly you do echo. That's also will done. But somebody might ask you in exam. That's why I'm telling you. So X-ray let us take. How would what are the findings in X-ray which you say to show heart failure of lung cardiac cause compared to chest? Yeah, that's the evidence. Okay. This big heart, never put only bronchodilators. I keep telling this in every class, every day, because I've seen only like this big heart. And did I show you that one end to other end, one heart was there? I took a picture. Recently, one patient came. Entire chest is heart. That patient is on bronchodilator man. See this man. I'll show you that. I'm not exaggerating. One side to other side, heart. The picture also. Okay, cardiomegaly is one. The more bigger the heart, the more worse it is. Right? This you should understand. The more bigger, the more worse. Then what else? Either ventricular enlargement, total cardiomegaly, or sometimes only atrial enlargement. LV may not be big, but atria may be dilated. Is possible? Possible. Yes. Which is a classical condition in which only atria dilated LV is now? One. But both atria dilated. Mitral stenosis is BAH and atrial enlargement possible. But in there, RV will be also. I'm saying both ventricles now. Only both atria dilated. Possible not. Anything is possible, but so I'm asking what? When? LV is normal. Both atria dilated. Huge dilatations of atria. Very specific for some condition. Suppose echo shows this picture. What comes to your mind? Both atria are hugely dilated, both LV are normal. One point of time, it was very common in Kerala in our country. Restrictive cardiomyopathy CT generally teaching. Restrictive cardiomyopathy, LV myocardial infiltrations could happen. Myocardial dilatation, late stage, everything will happen anywhere. Restrictive cardiomyopathy also, once it goes to failure, the LV also will dilate. So by and large, in restrictive cardiomyopathy, classical feature is ventricular size is normal, atrial size is hugely dilated. Both right atrium, left atrium, right? Both are elevated, more likely to be restrictive cardiomyopathy. What is the commonest cause in Kerala? I said is endomyocardial fibrosis. That was common. Okay, so that will have both restrictive cardiomyopathy is atrial. There also could be reason for heart failure, preserved ejection fraction. Other reason is pumping is good. Or this sort of amyloidosis, infiltrative disorder, sarcoidosis, all that can have restrictive cardiomyopathy. Relaxation abnormality, contraction abnormality is okay, right? So that is the regarding chest X-ray. Pulmonary venous hypertension, I think if you have X-ray only, you can tell. The cephalization, apex being upper lobe being more prominent, all that points PVH. Whereas not there, it is more likely, or the big patch is there, effusion is there below. All that is more likely to respiratory test. Understand? Sometimes peripheral pruning of vessels, we call it, is often missed. PAH finding. Pulmonary artery is dilated, but suddenly arteries blood flow in the lateral 1/3 chest X-ray is not there. So that is again suggests PAH, the cardiac condition, not lung condition. So those are some things abnormal in chest X. And echo, anything can be abnormal in echo. Echo is diagnosed. Systolic failure, diastolic failure, diastolic dysfunction, valvular cages, everything will be echo. Okay. Then coming to now that you know patient is suffering with heart failure, you know what is the functional class of that failure. Now you know what to do with that patient, right? So what is the standard description of treatment for heart failure? Patient comes to you with heart failure. First is identify a risk factor which is produced that follow. Treat it. Hypertension, treat it. Diabetes, treat it. CAD, treat it. Automatically it becomes all right. But irrespective of whatever the risk factor which is produced, what is the standard treatment for see this? I'm not joking, no, you must have thought that, guys. That's why I wanted to see this now. See this. One end to other end, no? Is it a joke? One end to other end. This is the chest X-ray of that lady, 4-foot Aron syndrome or whatever, Artner syndrome, what we had. I think this is the lady of that, I forget it. Huh? This also people give bronchodilator. Why I'm telling you, such a big heart. Please don't mistake. Such a big heart, what is the first different diagnosis you should come to your brain? Such a it comes to you. Huh? What do you think first? Very good. Very good. So such big hearts can only happen when the fluid is collecting around heart. But suppose bradycardia is not there actually. Yeah. Next best. Next common, huge heart. It's called as bovine heart. Huh? Bovine heart is called. Very common. Hugely dilated heart. One is pericarditis, correct. But if no effusion, only heart has to dilate. Huge big hearts are disturbed where which valvular arteries are disturbed? MS, MR, AS, AR, चार तो है, ठीक है? Where this bovine heart, huge big heart, aortic regurgitation can have hugely dilated hearts. Patients still may not have symptoms, so that's why they keep on going longer. Chronic heart is overlaid or dilated. Yeah. Then very rarely you can have mitral stenosis, biatrial enlargement, biventricular enlargement, failing, all that is late stage. That way anything can have anything. This lady had incidentally biatrial enlargement and PAH, TR. No, that's why I'm telling you. So that's also possible, but less common. First thing you should come to your mind is pericarditis. Okay, congenital heart disease, I say. Which congenital heart is more likely to have this? No? Tetralogy is normal heart. Reverse your normal heart size, decrease pulmonary blood flow, you suspect tetralogy. Not that is again because the Egon side that is figure of 8 appearance. There will be one more above, one more below. But heart can be bigger. Like transposition, you say Egon side appearance, that also can be bigger. But narrow pedicle with the side Egon side appearance, that is transposition, right? But more than that, big heart, huge heart, where is hugely dilated atrial described in that. Epstein. So when such a thing is described, you should also get into Epstein syndrome. Those are some of the things which I thought. And then pruning of vessels, pH, I told you, right? So this is about X-ray. We went to management also, treatment. Then so X-ray is suddenly got deviation. So now what is the treatment of about the risk factor? So 4:27 minutes will have to close. So what is the now heart failure management? What are the pillars of heart failure? The theory question also it comes. Sorry. Okay. What are the 4 pillars of heart failure? What is the 5th pillar which is coming up?
RNA,
Hmm.
SGLT2 inhibitors.
RNA and ACE inhibitors are
That's
one.
one. AC and
All these things are one.
beta blockers, SGLT2 inhibitors, MRS.
So generally, we never used to think mineralocorticoid receptor blockers are one pillar. Yeah, but mechanism of action is different. That's why they put. Or that also you can file it in AC inhibitor. Suppose something you want. Some common pathways are there. By and large. Okay. But what is the fifth one? Okay, not pillar. It is not proved as pillar yet. But something new. Could come a theory question for you. Okay, let us talk about ACE inhibitors and RNA. Yes. Previously, they used to say that ACE inhibitor should be given. If not, patient is not tolerating, RNA receptor blocker should be given. Right? So now the concept is changed. Either R is okay now because data with the receptor blockers is so much. Is either R is okay. Patient is tolerate, not tolerating, you put a receptor blocker. But even if otherwise also, you can put receptor blockers. So the receptor blockers block the angiotensin 1 receptors and action. That you know, no? So, but what is this funny RNA doing extra? Why is this RNA? Even if patient is stable on ACE inhibitors or receptor blockers, you have to still switch over the RNA. That's the latest concept. So, what is this RNA business? RNA is a wonder drug looking. It has changed outcomes of patients so much. Symptom relief for definite help. Compartment mortality reduction will also happen. So, what is this RNA? What does it do?
This naturalization is converts RNA is basically the inhibitor for also naturalization. This naturalization in
అంటే నేను మీ పేరేమన్నారు రాకేష్ మీకు అన్ని తెలుసు కాన్సెప్ట్స్ క్లియర్ ఉండాలి why always what I stress is concepts are clear, there's nothing like forgetting like this, right? So ABCD now you can never forget and that's try to understand, go to the basis, right? Previously what all ACE inhibitors receptor blockers were doing was we were trying to address only the ACE pathway, angiotensin converting enzyme inhibitor. Name is only there. We were only trying to block that, trying to block the bad effects of the bad molecules by either receptor blocker or prevention of conversion of angiotensin 1 to angiotensin 2. Right? We were only addressing that. But if you see suddenly, that is what is it causing? It's causing vasoconstriction, it is causing fibrosis, it's causing multiple troubles. Okay. Other pathway is there in the human body. What is other pathway? Vasodilators. Right? There are some molecules that God gave you to keep your blood vessels dilated. Okay. But we never addressed that pathway before. Those are good molecules, no? Like it is like morphine. If you give morphine, right? I'll come to bradycardia. So this neprilysin, what was it doing is neprilysin inhibition causing this prevention of breakdown of good molecules, which are vasodilatory molecules produced in the atria. A and B, B and B. What they were doing was they're food molecules. Heart likes it. Vasculature likes it. We were never addressing the prevention of breakdown of those molecules. First time this concept came, very good. No, why you didn't think like that? It will happen later once the research comes. Seriously, nobody thought of preventing the breakage of good molecules. That's also a good concept in heart failure. On the other hand, if you increase the good molecules, heart will really like it. It's like steroids. Patient put on steroids, he will feel elated, well-being. That's what happens with RNA. So RNA prevents the breakdown of this good vasodilatory molecules like BNP and other things. That is why that is the basic difference between sacubitril valsartan. The valsartan receptor blocking is there. Apart from it, neprilysin inhibition is there with sacubitril. So both is there. That obviously both has to be better than one patient. Coming to your bradykinin, one of the bystander problems of ACE inhibition was when you are doing that, it is also prevention of breaking down of bradykinin. So bradykinin levels were becoming high. That's leading to side effects of it. That has got nothing to do with our sacubitril valsartan, right? That's how we had a side effect of increased bradykinin, which is nuisance, allergy, cough. Whereas neprilysin has got nothing to do with it, right? So obviously you will understand, no? Prevention of breakage of good molecules has to be better than preventing only the bad molecule. That's how sacubitril valsartan did wonders. Then coming to SGLT2. Diabetes also, funny, because all these years we were thinking of only stimulating insulin or increasing the insulin secretion. Always we are thinking about insulin only, how to increase the production, huh? Or to give a drug which acts like insulin. Things like that. If you see the other way, no, just increase the excretion of sugar from the body, automatically sugar decrease. This we never thought of before. Huh? After so many years of research, it happened. What is it doing? Just increasing sugar excretion in urine. एक तो production कम करना, एक तो stimulation insulin करना. Third thing is increase the excretion of sugar in urine. Man. That's it. Later, I don't know why it did strike so much before. People tried, did work or what, I don't know. Simple. But apart from that, why just sugar going in urine is producing benefit in heart failure? Sugar control may be happening, better sugar control could lead to some benefit. Why is it causing so much good benefits in every aspect of heart failure?
Sodium.
It is not only with sugar, it's also taking sodium with it. Okay, that is bad. So taking out of sodium obviously will lead to benefits, it decreases blood pressure, leading to a lot of other benefits in heart failure. So that's how the not only sugar excretion, but sodium also is linked with it. That's how SGLT2 inhibitors have become one of the drugs in heart. Right? Proven mortality benefits. Both in systolic and the only molecule that is proven benefit even in diastolic dysfunction or heart failure with preserved ejection fraction is SGLT2 inhibitors. There are 2-3 different types of it. Which one you can remember? You can remember whichever you have favorite, you can use it. Receptor blockers, whichever you are liking, you can use it. Provided you give them in the proper dosing depending upon the half-lives. That you should understand. If you're giving losartan, you have to give twice daily because short half-life. If you're giving telmisartan, you give long once daily because long half-life. Same thing with empagliflozin, dapagliflozin, all this also same gliflozins. That is true. Then mineralocortical receptor blockers, again, they are type of diuretics. But again, for doing very what about diuretics then? Why diuretics have not become pillars here? Diuretics have only have symptomatic benefit, but no mortality benefit. That's why diuretics are not one of the pillars. Many of them confuse diuretics. What is the set of digoxin?
In regurgitant conditions with heart failure, which is
Generally dilated hearts. Regurgitant is one of it. Still there is some role for digoxin, but not for the other ways. Or heart failure with atrial fibrillation fast rate, still you might use digoxin, but otherwise not using. Why this digoxin became negative? Why it became less popular? No, toxicity. That's how it never became popular. Okay. And doesn't decrease the mortality, only symptomatic. And so digoxin, inotropes again the same. Right? So that is beta blockers again is important. Other important thing is beta blockers not only control the heart rate, but also has prevention. Many anti-arrhythmic benefits are there because of a crossing of lipophilic barrier. That's why sudden cardiac deaths are prevented by beta blockers. Okay. So beta blocker again, the later generation, third generation beta blockers are probably to be given, not the first generation atenolol or anything, because they don't have benefits of prevention of sudden cardiac. Okay. What is the most latest action in beta blocker? Beta blocker, huh?
Drugs.
Nebuvolol is one. What is the specialty of nebuvolol? What is so third generation about it? Correct. No, cardiac selective, many other second generation also cardiac. Third generation, I should have some other additional qualification. Right? Vasodilatory. Right? Vasodilatation of carvedilol, bisoprolol is slightly different from nebuvolol. Nebuvolol is supposed to be increasing the nitric oxide production, breakage, and then increasing nitric oxide, that's how vasodilation. That's specialty of nebuvolol. And whereas bisoprolol, other things do some alpha blocking also lead to vasodilation. That's a specialty. So beta blockers, which have this vasodilatory potential, are the best if possible. At the same time, they should not have side effects and produce metabolic abnormalities, derangements, increase in sugars and all that, which atenolol does. And these beta blockers should be lipophilic, so as to have the benefit of sudden cardiac death prevention. That's really important. How the beta blockers prevent is sudden cardiac death is also prevented in heart failures by beta blockers. Same thing is noted with RNA also. The fibrosis, interstitial fibrosis edema also decreases the blood. That's how we decrease the more sudden cardiac deaths also. Okay. So that's how those are the drugs, pillars. Latest version, the most latest apart from all these drugs is called, we're going to micro level, micro metabolic drug. Very sigwat is the almost addition, which is supposed to be a step ahead of guanylate cyclase inhibition, ahead of ACE inhibition, and that is supposed to be also doing some good. Some trials have come just with some little mortality benefit, but it's still not yet proven, not totally come to recommendation, but it might come in future. Right? Any new drug which is wonder drug noted for hypertrophic cardiomyopathy, Dr.A.Sreenivas Kumar is a new drug which came for specifically for decreasing the contraction, myosin, active myosin chain. It goes there and blocks, so the contraction decreases out. So that is mavacamten. That is supposed to be very specific for hypertrophic cardiomyopathy. Right? We are going to the micro level now. That's the research. The amyloidosis, anything has come? Tefamidis is a new drug which is common. It is actually specific for prevention of attachment of amyloidosis and creating damage to heart fibers. So now in diastolic dysfunction, we go to specific cause. Difference is apart from giving general drugs, etiological cause treatment is more for diastolic dysfunction and heart failure preserved dysfunction, whereas systolic dysfunction is broad, where these drugs are effective. In preserved ejection fraction, we are going and attaching and trying to identify what is the cause. Some particular gene is mutated, go subnormal, give gene injection, and prevent, might reverse. All that is the concept for preserved ejection fraction. Okay, so this is the management aspect. Management, all this. So any curative problem is there, it has to be corrected first. Valor is there, you have to correct it. Aortic stenosis is there, treat it. Okay, all that is fun, essential. Apart from it, no curative factor, then you give this all these four pillars of heart failure, right? Okay, for heart failure today is 4:35. Anything else you want? Anything doubts you have? Good heart failure. Harrison. Oh, you should tell boldly. Harrison is a good thing. No, you read full chapter of Harrison. He is a genius. No, because Harrison basically should read. If you don't read it, you'll never read it later. Huh? Like Brownwald, before getting into cardiology entrance, if not read Brownwald, you'll never read it. By the time you enter itself, you should know. Right? Really, read everything in Harrison, especially, I don't know, cardiology, so I feel very well written. But the thing also, Harrison, Davidson also, you want to read it. Everywhere book is Davidson. So, apart from it, each specialty you should try to read some other books also, apart from Harrison. Hello? Okay then, right? Thank you. You try to see any patient if you have in between.